Hi, welcome to another episode of Scaling Vision podcast. It is my honor today to be here with a very international faculty, Dr. Keshav Singhal. He has changed the entire landscape of orthopedics throughout his years. Welcome to the podcast, sir.
Thank you, Samir. It's a real pleasure to be here with you.
So before I go deep into whatever I want to talk to you about, I want to I want you to tell me early life in Gwalior and GR Medical College, sir.
So, Samir, I was born and brought up in Gwalior.
Right,
Studied in Central School Gwalior, then went to GR Medical College, and I think those were the wonderful years of my life. GR Medical College in particular, I must say, it was an amazing medical school. And we had wonderful friends. The friendship. Anant, your father, he was one of my closest friends in medical school. And we had a wonderful time. And, we had very good teachers.
Right.
The clinical teaching was superb. And I think, fortunately, all our batch, they were very well settled because the teaching they had, that made them really successful doctors in every specialty and across all of the world, not just Gwalior, not just India. But people are there, they're putting their imprint everywhere on the medical landscape.
I remember, sir, because when I first went to medical school, we had a book of anatomy called by Dr. B.D. Chaurasia.
Yes.
So when I bought that book, my father was like, this man has taught us, he has taught us how to do dissection and stuff. There was the micro, I don't remember. Dr. Park was also taught you about preventive and social medicine.
Yes.
I mean, you all literally were taught under stalwarts of the country, sir. I feel very jealous, actually.
Well, I'm sure you also have very good teachers.
Yes, sir, obviously. But why orthopedics, sir?
So it's a funny story. I always wanted to be an engineer. Now, my father, he was a doctor.
Okay.
He was a professor of anesthesia. He was fully agreeable with me. Said, yeah, go in engineering. My grandfather, who was an engineer, said, no, you've got to be a doctor.
Okay.
So I got admitted in IIT Bombay. When they took admission, gave my fee, came back. And my grandfather went on भूख हड़ताल कि बेटा मैं तो तब तक नहीं खाऊंगा खाना जब तक तुम डॉक्टर बनने के लिए तैयार नहीं होते. अब ठीक है यार, 16 साल का बच्चा. I said, okay, it's okay. But that passion of engineering and doing something with my hands, that stayed.
Right.
So then I became a doctor. Then what is the thing that I can do with my hands, which is similar to engineering? So orthopedics was a logical answer.
Right.
So that was a no-brainer.
It's a wonderful story, sir. But then you transitioned to Liverpool for your further studies after ortho.
Yes. So, in those days, it was absolutely, Liverpool was the mecca of orthopedics. There was only one MCH degree in the entire world, which was Liverpool. And everybody came there from all corners of the world.
Right.
And in India, it had a great prestige. So I went there to get the degree. Fortunately, when I got admitted very soon. I was one of the youngest people at that time to get that admission. And that was a very good formative degree.
Right,
Taught
sir.
me a huge amount.
But did you face any challenges getting accepted into the UK system?
There are always challenges,
Right.
When you are there as a foreigner, as an international medical graduate, you have to be 200% better, 200% working harder. You've got to show them of your capabilities and of the passion, and that you've got the capacity to do hard work.
Right.
Then they accept you. Once you actually show it, then it was easy.
Do you remember your first independent joint replacement case? What was it feel like?
So this is in Birmingham. So after Liverpool, I went
Right.
into the higher training scheme of Birmingham, the Royal Orthopaedic Hospital. Now I was hesitant. So my consultant, he somehow saw something in me. And one day, as I'm scrubbing, he says, Keshav, I've got an important meeting, carry on. I said, but Mr. Thomas, I haven't done a joint replacement on my own. Oh, you'll be all right. And I was panicking a little bit. I knew I could do it, but it was the confidence.
Right.
But then when he said you can do it, gave me a lot of confidence. So I went there. I did it, and I had a lot of sense of achievement. Yeah, I've done it, and I've done it well. So, and then I realized how important it is for a teacher to leave the student at some point on their own. Otherwise, they'll never get that confidence.
I remember my mentor when I was doing my residency. So we were always trained to do stepwise. You proceed the training in surgery step by step. When we had mastered all the steps, my mentor said, now you do this case independently, I'm standing here. When I did around 10 to 20 cases, and he's not going to cause any complications, he said, you keep on continuing, I'm standing behind you. Now when you're operating, all your focus is in that particular segment of when you are, and you lose the sight of your surroundings. When I finished my surgery and I turned around, my mentor was not there at all. And then I started panicking in retrospect, yaar kuch ho gaya tha to. But that also gave me a very big confidence boost. Yeah, I can do it.
Yes,
I totally agree with what you say. You have, when did you do this ERAS, early recovery protocol, sir?
Oh, this is a long time back. So, I won't say that I invented this. So the concept of this had been around in Europe very long time back. So we're talking probably of 2002 and 2003. And I found out there was a hospital in near Amsterdam which was experimenting with this concept. So I went over there and I took a team of 20 people with me, colleague surgeons, nurses, physiotherapists, and we went and saw that. And then we brought some elements of that back and we experimented with our own protocol and we set up our own protocol. And the ERAS stands for Enhanced Recovery After Surgery. And the thing was that in the old days, I'm talking 20 years back, after a joint replacement, a patient would be in the bed for 2 days. And the total hospital stay was 10-12 days. So we said, this is not needed. So we said, okay, we need to make sure the pain is well controlled. And if the pain is well controlled, we can get them out same day. So we started that. So 2 hours after the surgery, they were walking to the toilet independently. And because there was no pain and the joint replacement, we were confident has been done well, they could walk and we had no issues. And the patients also then started driving this forward. So in the initial days, there was a lot of skepticism. So my patient is in the bed and the patient is going to the toilet 2 hours later. The next door patient is somebody else's patient, and that patient is in the bed for 2 days. And that patient started asking the ward sister, why I'm not walking and that person is walking. And those patients that drove that change, so eventually I started it in my hospital, probably around 2005. And within a matter of a few years, it had spread across the whole of the country.
Oh, nice.
So it is now totally embedded in all of UK and in fact all of the Western world.
Okay.
And it's changed orthopedics completely.
So basically, you control the pain, inflammation, and you have better patient outcomes, so satisfaction.
That is one of the things. Yeah. You have to do some prehabilitation.
Yeah.
So we need to make sure the physiotherapy starts before surgery.
Okay.
We take a class of the patients in a classroom setting and we tell them exactly what happens in the surgery, how they do before, how they progress after. So the patient has to be mentally prepared. So instilling confidence in the patient is so important here. An educated patient is a good patient.
Obviously. Let's talk about the KS alignment system. You have a patented technology for all the doctors who are watching and non-doctors. Please tell them what is the KS alignment system.
Yeah. So this is a alignment device I invented for hip resurfacing. So for a total hip replacement, it is very simple that you cut off the femoral head and then you put in a stemmed implant. Hip resurfacing is a totally different concept where you actually put a cap on the femoral head. And it's very critical that that alignment is perfect.
Okay.
So I used to teach in Vienna at the international hip courses. And one day we were sitting in the cafe in the morning before the course. And suddenly it hit me that, if I do something like this, then it'll make things very easy. Because the previous alignment devices were very fiddly and you could never be sure of the alignment. So I had an engineer sitting with me. I drew something on a napkin and I said, look, This is the concept. Do you think this will work? He had a look at this. Yes, I can give you a prototype in 5 days. So I gave him a design. He gave me a prototype. Within a month, we had refined it fully. And we had a first functioning model. We tried it on our patients, and it was super. So then, in fact, I came to Bombay. We brought a team of 20 people because we needed to do a cadaveric testing.
Obviously.
And we had no cadavers anywhere else.
Yeah.
So in DY Patil Hospital in Navi Mumbai and in MGM, we got 20 cadavers each. We brought a team over. We did half of them with my alignment device and half with computer-aided navigation. And we could prove that this alignment device was better than computer-aided navigation.
Wonderful. What year was this, sir?
This was 2006.
Kya baat hai. And are doctors still using this today?
Doctors are still using it, but unfortunately, the hip resurfacing went into a bit of disrepute.
Okay.
Because one of the orthopedic giants, they produced the implant which was not of the right metallurgy.
Okay.
So it started creating problems. Plus, a lot of surgeons, because this was a very new, glamorous and sexy operation, a lot of surgeons did it without proper training, so there were bad results.
So suboptimal results.
Yeah, because of all these factors. So now only very specialist centers do it, but it's, so the people I operated upon 25 years ago, they're still going strong. And I totally believe that they will actually finish off their whole life with that single implant.
Wow. This is your confidence, and I think it comes from seeing your patients again and again for multiple follow-ups.
We do follow very, very regularly.
You were also appointed as the chair for the British, Asian and marginally ethical community in the COVID-19 risk assessment group of Wales. What is that about, sir?
So, when COVID struck, we very soon realized that the mortality in the ethnic minorities, Asians, blacks, people like us, was much more than the mortality in the white population.
Okay.
So I started looking at it and I said, why is this so? So it's not as if so the blacks have a genetic predisposition because of the sickle cell issue.
Right.
But in our ethnicity, Southeast Asian ethnicity, there's no major issue apart from metabolic syndrome. We're prone to, diabetes, hypertension, visceral obesity. So I started looking at it and I talked to our ministers and I said, we've got to do something. The doctors of ethnic minority were dying in big numbers.
Okay.
So they said, okay, we'll set up a committee, official government committee, you head it, and you come out with a risk assessment tool. So how we can risk assess people and say, you are from this particular risk group, so you need to take these precautions.
Right.
And our brief was very simple, that we need something out within the first 2 to 3 months. We need a tool.
Right.
So that everybody was preparing a risk assessment tool at that time. And the question was how we come up with something very simple, something you can do a self-assessment. So I had some idea, so I drew up a scale, and the scale was based on your age and sex, your ethnicity, your comorbidities. So if you had, say for example, hypertension, you got one number. If you had a waist size over, say 36, you got one number, and so on. We came out with a tool, and that you could actually tick, and do it in 5 minutes flat. Everybody could do it.
It's a self-assessment
tool, and it was spread out across all of Wales and most of UK. And it saved lives, because we could then say, people could say, my risk assessment is showing me I'm a very high risk, so I should not be in patient contact, direct frontline contact, and that we could keep them safe. Now, there were other risk assessment tools. They were also very good, but they were based on heavy data use. So you had to go into the patient records, and that became a cumbersome thing. Time-consuming, impractical.
Very true.
So, no, I was very, very pleased with that, and quite proud that our committee could come out with something very useful.
You also received prestigious honors like the CBE and MBE. What do those signify, sir?
So these are, our honor system in India, Padam Shri, Padam Bhushan, it's the same sort of thing. So this is the MBE is the member of the British Empire, and CBE is the commander of the British Empire.
Right.
So MBE I had got in 2013, and that was again for medical work, but also I'm quite heavily involved in inter-community work, promoting Indian arts and culture and so on. So that was, and the CBE I got in 2023. So that's exactly 10 years later. And that was a wonderful experience. So the MBE was at the hands of King Charles, who was Prince Charles at that time.
Right.
And the CBE was by Princess Anne.
Oh, nice.
At the Windsor Castle. And it's a wonderful ceremony, and it's a great honor, I think. Really.
What does it feel like to be in that castle, sir?
It's amazing.
It's a real
They really take such they make you feel very important. It's anybody who's coming there for that honor, they take care of you. And this thing that struck me was that the monarch, the king or Princess Anne, for example, they are briefed about who's coming.
Okay.
So they could engage into a conversation with me for 3 or 4 minutes about what do I do, what I specialize in, where I am from. And I thought that was so powerful that they took that trouble to be briefed and to know about you.
It's always that extra effort that counts a lot.
Absolutely.
Yeah. What is the best of both worlds? Indian medicine meeting British medical systems. You have seen, over many years, I'm seeing.
I think it's when two systems meet, there's always a good synergy. So from the Indian side, the strengths are our theoretical knowledge, which is superb, our hierarchy that we respect our teachers, and in turn we get so much back from them, and the fact that we have got a huge patient pool. So the numbers we see and the variety of diseases we see is amazing.
Yeah.
On the British side, I must say the discipline, the fact that there's a protocol-driven approach, so that you don't miss out anything. So it's not as if I could diagnose somebody walking in the door, but that's not good enough. You have to put it through a rigorous checkbox and make sure you're not missing anything.
Right.
So it's when these two things come together, I think we get a wonderful balance of intuition and knowledge, and then discipline and protocols.
Right.
And I think that's why Indian doctors anywhere in the world, when they go out of India,
very respected.
They do so well.
Yeah. But you've been abroad for like major part of your life, sir. And you continue to live there. What do you think is going wrong with NHS nowadays, sir?
So yes, NHS is in a bit of a problem. That's to understate it.
Yes.
I think the demands are too much on the system.
Okay.
Because we've got aging population. And everything now involves, the least is MRI. Patients demand it.
Right.
So the system doesn't have that capacity. And what that causes is long waiting lists. Like in orthopedics, for example, my NHS joint replacement waiting list probably is over 18 months.
It's too much.
Well, it's come down actually. After COVID, the waiting list was nearly 2.5 years. So it's coming down.
Okay.
But that's too much.
Yeah, that's too much.
And that's because, the aging population, people need, and they also are much more demanding in terms of lifestyle.
Okay.
So say, I want to be absent of pain. I don't want any pain at all.
Right.
I want a joint replacement. Now you only got so much capacity. But here I think we can in UK learn something from India, and that is high volume surgery.
Exactly.
I think India is miles ahead of any other country. So some of my colleagues here are doing 18, 20 joint replacements in a single day.
Yeah.
Using multiple theaters.
Yeah.
And I think we need to learn from that.
But why doesn't NHS have that infrastructure and India manages to have that?
Well, this is what, Indians have that innate capacity of thinking out of the box.
Right.
I think that is why Indians, wherever they go, you see Google, you see Microsoft, everywhere, they're so successful because they have that capacity.
So is there opportunity, since there's a scarcity of doctors, there's a high demand for work, Is there a possibility for Indian doctors to move to UK and look work within the NHS?
Yes, so there's always a possibility. And in Indian doctors in particular, we've got an association there called BAPIO, the British Association of Physicians of Indian Origin.
You were the governor of that.
I chair the Welsh National Division, and BAPIO is doing a lot of work in India.
Okay.
So BAPIO's got its body called BAPIO Training Academy. In fact, my brother Parag, who's again from the same medical college, he heads that. And we have collaborations with about 20, 25 big Indian hospital chains like Max and Apollo and so on. And we train Indian doctors here for 2 years in those hospitals. And then we take them to UK for a two-year further training. So there's that's happening. But I must say, currently there is a strong public sentiment against immigration.
A lot of political scenarios very different.
Yes. So I think, anybody who goes there needs to be very clear. So if you want to go there for a training period for 2, 3, 4 years and come back, fair enough, that's good. But if somebody is planning to go there to settle, I think that's not the right time.
But let's say in terms of your business perspective, somebody from India says you are a country which has a lot of waiting lines and diagnostic machines at least. We come up there and we set up a diagnostic center. Is it possible? Will the government allow it?
Yeah, so Devi Shetty has just bought a hospital chain there.
I know, I was reading about it.
So yes, there are opportunities, and there's also opportunity for the UK patients to come over in India as medical tourism, and I think that's also started in smaller numbers.
Yeah, medical tourism is booming in India, sir. I think it's growing by almost 10 to 11% year on year. In terms of not orthopedics as a large wholesome picture of multiple pathies. I just forgot, sir. Now we are seeing a lot of robotic surgeries in joint replacement. What's the hype versus reality picture in such cases?
Okay, I think that's a very interesting question. So robotic surgery, obviously, if done rightly, is more precise. Now, whether that precision makes clinical outcomes any better is open to question at the moment.
Right.
We don't have the data. I think I have slight concerns about robotic, because I think what it'll do is dumb a generation of surgeons who want to only operate with the robot. So in case they have to use their own skills, their own eyeballing, they won't have that capacity.
Absolutely.
And also with the robots, you're totally dependent
on
something else. So rubbish in, rubbish out. So if your data points that you feed in are slightly off, then what you get is not right.
Right.
So I think both human mind and robot should coexist. So the surgeon should not be totally dependent on robotic.
Right.
But we will know in another 10 years whether the precision obtained by a robot translates into better clinical outcomes.
Nice.
Now, it's a good thing for a bad surgeon. If you are a surgeon who is not confident in your abilities, then a robot will make you a better surgeon.
Yes, very much true. There is also, I've been reading about some newer tools about biological joint preservation.
Yes.
What is that, sir?
So I think that is probably the next challenge in medicine. And I think in the next 10 years, there will be some such cure which can regenerate your cartilage or prevent your cartilage from getting worse.
Okay.
And I think if that happens, then all this joint replacement surgery is going to go out of the window.
Yeah.
And I think that will happen.
Right.
And I think for the patients, that will be a very good thing.
Yeah. What do you think about these patient-specific implants?
Again, it's the same thing as the robots. So patient-specific implants do make surgery easier, but they increase the cost.
Right.
And they come at the cost of radiation to the patient, even though it may be fairly small, but there is radiation involved in terms of scanning and so on. So I'm not sure if it'll actually become mainstream. I think it'll stay. There are exponents of that technology. They do it. They swear by it. But in the NHS in UK, there's no drive towards mass adoption, either robotics or patient-specific implants.
the way you talked about, we are talking about joint preservation. So recently an article came out somewhere from Japan, I guess, if I'm not mistaken. They have found the specific gene that causes cataract changes in the eye. And now they are trying to play around with it with the help of CRISPR. And if we can do something, gene editing, changing the telomeres here and there. So we'll be seeing no cataract in patients, or a reversal in people who have already had a cataract. So the need for, as you said, orthopedic surgery and probably the need for cataract surgery, आगे पीछे, is maybe 20 years down the line, पर वो होने वाला है.
Yes, I agree. CRISPR is a wonderful technology.
Yeah. So with these all new technologies, sir, is there any change in the post-op recovery of the patients? Can we do tele-rehabilitations with patients nowadays?
Yes, that I think that is on the cards. So once again, when you have taken a class of that patient before surgery, reinforce those exercises during the 1 or 2 day hospital stay, then you can actually do it. So it's like you are doing podcast. You can be podcasting those exercises to a group of patients at the same time. That cuts down a lot of the travel, lot of time and resources. So you are actually, streamlining everything.
Very nice. So you build systems around it, and you can just probably send the same video to every patient about that, right? Now this is a very different tangent I want to take you on. You are mentoring the next generation of surgeons. What difference are you seeing over the years? The change in doctors that you see?
I think I'll be a bit controversial here.
Yeah, go for it. I like controversy.
So, in our generation, there was no concept of time. As in, there was no work-life balance. So if you were in the hospital, like I remember in my MS days, we only used to get a half day off in the whole week, which was half Sunday after lunchtime.
Right.
And when I first went to UK, I was working in some of my jobs. I was doing a 1 in 2 on call. So I'd be on call in the hospital 24 hours every other day.
Right.
And I think that gave us a lot of clinical exposure. It made us, it gave the patients a lot of continuity of care. And then came the European Working Time Directive, at least in UK and Europe. And that restricted the total time you can work. I think it was something like over the week, 42 hours or something like that.
40 hours.
And that meant if you did a on-call, 24-hour on-call, you had to be off nearly 2 days after that.
Yeah.
So no trainee got the opportunity of seeing the patient in the clinic, then in the theater, and then in the recovery and in the clinic again. So that continuity of care is no longer there.
Right.
And I think the current trainees actually do suffer because of that. And it is only after they became a consultant that they start then having their continuity of care. And I think when we became a consultant, our generation, we were much better prepared to take on those responsibilities.
Happens.
And I don't know what's the situation in India, but I think it's probably better than what we are seeing.
It's much better because, sir, we have a system of residency. When during your 3 years of residency, there is no sleep schedule. You are basically living in the hospital itself, there's a room. You have a break, but your life entirely revolves around the hospital itself. It's not as difficult as you say. It's half a day off during the week. It's still very much tight, but we do get to see the continuity of patients. You will see the patient in OPD, you will admit the patient into the IPD, you will do all the IPD checkups, all the grunt work that's done by the resident. You'll prep the patient for surgery, part preparation, everything. You'll watch the surgery, your senior is going to ask you questions, what am I doing? They're going to teach you. Post-op dressing and all, as a resident, you have to do it. You have to keep on doing it. And you have to discharge the patient. So, not in terms of orthopedics itself, in every department, it's more or less the same.
That's good.
Things change when you come down outside. Because suddenly you were working in a very high volume segment in a hospital, and suddenly you come out and you have no work, or you go to private hospital where the workload has decreased. That is a very shock that every doctor gets. But what you were saying is completely different. And I think a lot of doctors are adopting technology like we have never seen them adopt. At least in terms of ophthalmology, we're churning out fantastic doctors, sir. Fantastic. Moving on, sir. Due to philanthropy as well, right?
Yeah.
You teach philanthropy.
So most of my spare time is actually spent on community affairs, and we have a very big Indian community center which we call India Center. And our aim in total is that not only do we do philanthropy, but we also try and integrate the Indian society with the other communities and with the host community.
Right.
Because, once somebody has taken a decision that they're going to live in a different country, then we need to make that effort to make sure we all get together, that they understand us, we understand them, and we do not stay in isolated pockets.
Right.
Because that is when resentment starts. So that is what this center does, and I've been leading it for the past 20 years, and I think we've done a tremendous job. So for example, we started doing a Diwali Mela 20 years ago with the National Museum of Wales. So it's a premier institution. We said, look, let's do it. Let's make sure that we showcase Indian arts and culture, and we involve the local people. And we just this year celebrated 20th anniversary. And there, we've been having 5,000 people turn up at that Mela. All walks of life, all religions, all ethnicities. And I think that gives me a lot of satisfaction that, we managed to do something which brings people together.
Very true.
Because everybody likes good music, everybody likes good dancing. And that is where we are mostly paying attention to. And then, we've just recently started a Feeding the Homeless People's Initiative at the India Center. I think the first one was just yesterday. And I think that's also something very good because, unfortunately, poverty, we think Western countries don't have poverty.
No,
well, that's not true. There's a lot of poverty.
A lot of homelessness.
And there is homelessness, the unfortunate people, they need some help, and we try and do it.
In fact, I think drug abuse is more prevalent in Western world as compared to this side of the world.
That's true.
What are your views on leadership and empathy in medicine, sir?
Empathy is the heart of what a doctor should be. If you don't have empathy, then it's difficult to imagine what you're doing as a doctor. So I think that is easy. Leadership, I think, a lot of us have difficulty understanding this concept. A lot of us, including me in the old days, used to think if you put somebody in a position of authority or chair, you are a leader. No. So that's a position of chair or authority is purely for you to be able to take decisions, but how you take those decisions is the leadership.
Right.
How you actually inspire people, how you bring out the best from somebody, how you encourage them, mentor them, teach them, let them grow as a human being. And in that process, you make sure that the organization actually benefits.
Right.
Because when you've got people who are committed and enthusiastic and eager, then they work better. And then the organization, the hospital, or the whole institution becomes better. And that is what leadership is all about. And it doesn't come from sitting into any position. Leadership, you are a leader, I'm a leader, all of us are leaders in our own ways. Because when we start thinking about how I can make this better, that's leadership.
Obviously.
How I can make my junior work better, that's leadership.
Yeah.
So I think there are many facets of leadership, and none of it is connected to sitting in a chair.
Wait, I think you nailed it on the head. It's leadership doesn't come from sitting on a chair, definitely. What are some key values, sir, that you have sustained over the years?
So I would say hard work is very important. because unless you're prepared to work hard, you will not succeed.
Yeah.
And the second thing is persistence. So doing something and letting go at the first sign of failure is going to be doomed to failure.
Right.
Number 3 is honesty. And most important, which my father taught me, was at the end of the day when you go to bed, can you honestly say, I did my best?
Yeah.
Or would you have that regret that I could have done better? So if you worked hard with honesty, and you can say, I've done the best I could have done, because anything beyond that is not within my capability, I think you will sleep well. And I think those are the things I would say are very important.
So, looking back, do you regret not going to IIT Bombay?
Well, that would have been a very different trajectory.
Right.
I don't know whether it would have been better or worse, but I think God gave me opportunity to put my passion of engineering into medicine.
Right.
And I'm very grateful to God. I'm very thankful that I could utilize some of my passion and my, I think, some ability to design something in coming up with whatever I've done. And I have no regrets.
Fine, sir. It was a pleasure having you here, sir. Anything else you want to talk about, sir?
Thank you, Samir. I think you've exhausted me already. It has been a real pleasure sitting here. And you brought back a lot of memories flooding back from my college days. So thank you very much for having me.
Thank you, sir. It's been an honor.